Hey everyone, good morning. Let me know if you can hear me and how you're doing. All right, sounds good. We got 2 weeks left. It's pretty exciting for this semester. I'm gonna start in just a few minutes here. Let me know if you guys have any questions. Pop it up on the sticky board. Looks like I have a few over here already. It's good morning. And the semester's about to slaughter you? I doubt that. I bet you're gonna be quite successful, if I had to guess. I think 2020 is more likely to slaughter us than any test could do. Just the year in general. Still have the rest of November, December for the aliens to show up. That's what I'm waiting for. All right, well, it's 8 o'clock on the dot. Let us begin. Start recording here. Just to start out, I know it's election day, so hopefully if any of you have had the opportunity or going to take the opportunity, please do vote. I don't care who you vote for, but if possible, it's good to have your voice heard because I think it's going to probably matter in this one just a little bit. Okay, so let's go over a couple of questions here that you guys had. So someone was saying, if you have a patient taking a statin and you're looking at adding a non-DHP, is the CYP3A4 inhibition an absolute contraindication, or would it be an option to decrease the dose of the statin to compensate for the decreased CYP3A4 activity? Very good question. So it's not an absolute contraindication, but you are kind of playing with fire to some degree. So you gotta be careful, right? So you want to take into account, like, what's your patient's like baseline liver function? Like, has it budged with the addition of a statin? Have they had any myalgias? Things like that. If they're pretty well stable on it, you can consider adding on verapamil or diltiazem and then adjust your dose down because you know it's going to go up. You know levels of the statin are going to go up. But remember which ones are particularly affected by that, right? And so two of the big ones we were talking about tend to be simvastatin and atorvastatin because those are two of them that kind of fit that moderate to high intensity. Obviously simvastatin doesn't really fit the high intensity, but those are two very common ones that are affected by CYP3A4. So could you do those two together and then drop your dose of the statin? For sure, that would be reasonable, but again, you're going to have that patient follow up and monitor pretty closely. On the other hand, though, could you switch them over to something that doesn't interact at all and still get the same statin effects? That's pretty reasonable as well. So you kind of have either option available to you, but it really depends again on patient situation, costs, all kinds of things that kind of fall into that. Okay. Let's see. Someone said on slide 68 from last week's lecture, you're talking about treatment for angina. When you say treatment strategy, aspirin, beta blockers, ACE inhibitors, lipid lowering therapy, and sublingual nitro, are all these being used at once and for only a short period of time until their symptoms are under control? Thank you. So recall it, why are these patients having angina in the first place? Well, most commonly it's going to be because they have coronary vessels that are being occluded, usually due to atherosclerosis and other junk kind of building up, right? So you could put them on all these therapies and they can get their symptoms under control. But then once you take them off of it, if you haven't done anything to open up that vessel, which is really only done by treating them with, undergoing a PCI or something like that, actually taking to the cath lab, their symptoms should come right back to kind of where they were. And recall which one of these drugs are going to be better for either treating symptoms, controlling symptoms, or those which are going to be good at trying to prolong life, right? Like an ACE inhibitor is not going to do anything for their symptoms of angina, right? But is it going to keep them alive for longer? Possibly, right? The statins, those are going to be more for prevention of acute coronary syndromes in the future. Again, extension of life, not necessary symptom management. But yeah, you're going to put all of them on. They're typically going to be on all of these at the same time. Certainly the aspirin, certainly lipid lowering therapy. Sublingual nitrate, again, is like your quick acting sort of medication they need to be on there. Beta blockers, assuming they don't have any contraindications to being on beta blockers, and then ACEs for sure, as long as they don't have any big issues with that. Obviously, an ARB could also fit that bill as well. So yeah, I mean, these patients' medication lists can kind of explode on you before you know it, just based off what the guidelines are recommending and all of that. So yeah, they probably are going to be on a lot of these drugs at the same time. Could you have any combos? They're probably not of these drugs in particular, but yeah, where you can, if you can use combo drugs, it is helpful. So hopefully that answers that question. Someone was saying on slide 103, it says that beta blockers are first-line therapy for class 2 to 4 heart failure. Is this still meaning only carvedilol, metoprolol succinate, and bisoprolol, or is this including the whole class of beta blockers for second and third gen? For my purposes, if I'm asking about beta blockers in the context of heart failure, I am going to be referring to those three. So I would definitely keep that distinction in mind. On that slide, it was more of just kind of broad categorization of like kind of what would you see beta blockers being used for. So hopefully that clears that up. And someone said, I don't even know where to start studying. It's getting overwhelming. I know the feeling. Do you recommend knowing the drug MOAs, electrolytes they could affect, and their overall result for like a basic understanding at first? That's a good start for sure. You should know all those things. And again, I'm sorry you're crying so much. I can't even see the mouth on this emoji. It's very sad. But the big thing to do is to try to like lump all these drugs into categories, right? Don't waste your time trying to remember every detail of difference between propranolol and metoprolol, blah, blah. Like, you got to lump everything into buckets, essentially, right? It's going to help you keep these drugs separate in your mind. Kind of like what we've been doing for the past, sections. So, and we'll have a review next week. Next week is going to be kind of going through case studies, is going to be trying to kind of coalesce all this different cardiology stuff together into kind of one cohesive whole, so that way you'll have a better kind of understanding of the topic. So don't get too overwhelmed yet. Just kind of take it piece by piece. Remember, attack it from a group setting rather than an individual drug setting. So know a lot of stuff about ACE inhibitors, what kind of adverse effects you might see, what kind of mechanisms you might see, and then be able to identify drugs that fit within that category, right? So instead of memorizing every detail about lisinopril, it's easier to memorize all the details about ACE inhibitors and just be able to recognize that lisinopril is a drug within that category, if that makes any sense. Obviously, it's easier for some classes than others because the naming convention tends to make it pretty straightforward. So you can pretty well identify a beta blocker versus an ACE inhibitor because the naming kind of helps you with that, but it's okay. And the quiz this week, too, is going to be able to help you sort of start to make those delineations as well. So the quiz has some matching and things like that. The matching actually works this time, which is a benefit. And some, sample questions. So that'll give you an idea of kind of what we're looking at. We'll kind of wrap things up next week, and then you should be set for the test. So do not despair yet. We have plenty more time to do that for sure. All right, so let us move on into our PowerPoint here. So this is kind of the last section of like brand new material, so to speak, before we get into next week's review and case studies to kind of wrap things up a little bit. But let's start talking about our antiarrhythmics, and in order to do that, I want to make sure that we are sort of on kind of on an even baseline in terms of what we understand about cardiac conduction. So is this going to be a review for you at first? Quite possibly. If not, then I hope that will help you out in order to help you understand the electrophysiology of the heart. So anyway, so let's look at the electrical activity of the heart. Obviously, we know that the rate of the heart is typically going to be set by our pacemakers, right? And when I say pacemakers, I'm typically talking about the SA node, which is going to be sort of the primary one there, and then also the AV node as well. And if you have someone who actually has like their SA node like ablated and wiped out, their AV node will still take over, right? So it's kind of this hierarchy where the SA node is sort of the top, and then it kind of goes down. And as you get down to kind of lower and lower levels of pacemakers, their rate actually, or their intrinsic rate actually slows down a bit. So for instance, even if you got rid of your SA, AV node, and Purkinje fibers, if it was just the ventricle setting the rate, you'd be at around 20 to 40. So not real compatible with life, but better off than having no rate at all, right? And so remember, the whole point of the pacemaker cells is to set off these action potentials that lead to myocardial contraction, right? So for instance, here, if you're looking at this red line, those are going to be your pacemaker cells, where you can see their electric potential. And again, we're talking about electrophysiology, so we're talking about electricity basically today. What you can see here is that you'll have this resting membrane potential, and that as the pacemaker cells start to get it to a certain threshold, this is where they discharge, right? And that's why they then reset, and then they have another influx of ions to cause the potential to go up, and then they have another discharge, right? Every time one of these discharges happen, that signal gets sent down throughout the heart, and that's when you have like your ventricles actually beating, right? So again, you want this tight pairing between your pacemaker cells and the ventricles beating. If there is a disruption here, that's where we start to get into dysrhythmiasm. So we're going to look at how we end up managing those. So again, when you're looking at this, SA node is going to spread its wave of depolarization throughout the atria, which is why you'll see your atria contract first. And then that signal will then travel through the AV node down through the Purkinje fibers, through the bundle of His and all that good stuff, and then will then spread through the ventricles, right? And if you look at it, actually pretty wild that our heart is so well developed to do what it does, because again, that signal that depolarizes throughout the atria is blocked from going into the ventricles unless it's going through the AV node and down to the Purkinje fibers and all of that. So that way, this initial depolarization just doesn't cause the whole thing to contract at once, because that wouldn't really be all that efficient if your whole heart just kind of clamped down, as blood's not going to go in the right direction, right? What I think is really cool too is how you actually see that the signal travels down to the bottom, the apex of the heart. You can notice here that the actual contraction of the ventricle starts at the bottom and then squeezes upwards as that signal kind of goes up through the ventricles here. And so that again allows us to be able to be very efficient at squeezing blood out through the ventricles and into the aorta, for instance. So pretty cool that our heart is developed the way that it has to work in this very nice synchronous sort of mechanism here to get blood going where it needs to go. Human body's pretty cool, as it turns out. So anyway, and again, here's that intraatrial septum, and then the actual septum here that will divide up between the atria and the ventricles. And it's important to have that signal being blocked, because again, you don't want the whole thing to start contracting all at the same time. So again, understanding how this electrical physiology works normally is really important to understand what happens when things go wrong, as we're going to see here in just a little bit, and then ultimately how we treat it. So let's look at the myocardial action potentials first. So let's going to start off with our cells that are not going to be not pacemaker cells, right? We're going to be dealing with the cells that actually are going to be the ones that causing the contraction of the ventricles to actually move blood around. And we're going to mainly focus on the ventricles because that's what's really going to be pumping the blood, giving us blood pressure, cardiac output, all that good stuff, right? But anyway, so what you're going to see here is that most of the myocardial cells are going to be what we call fast response cells, meaning that they will, unless they are triggered by an action potential, they're just going to be sitting there at a normal resting membrane potential. Nothing really is going to happen, right? Until they get a signal that says, okay, let's contract, let's fire off an action potential, which you can see here. If you notice that you'll have, the resting membrane potential being somewhere around negative 90 millivolts, and you'll just sit there for a while until an action potential comes along. Then you're going to get the depolarization, okay? The initial depolarization occurs, and I'll talk about the ions that actually causes that to happen. You'll then get sort of a nice plateau phase here where you get nice sustained contraction, and then you have to repolarize. This step is extremely important because if that doesn't happen, then you can't get ready for another contraction. And we're going to talk about refractory periods and all of that as we get into it, right? So again, depolarization, plateau, repolarization, then boom, you're back at your resting membrane potential again. Okay, so what's actually happening here, and this is going to be important in terms of determining what our medications are going to be doing. We're going to be seeing a few different targets for our different medications to work on in order to change how this depolarization happens in order to treat arrhythmias, right? So we're going to see what happens here. So basically, we're at a resting membrane potential. You're going to be finding that initially you're going to have sodium channels open up, okay? So some signal has come down to this ventricular myocyte. You're going to see these sodium channels open up and you get this really big spike in potential, right? It's going to go positive here. Recall the ion and the electrolyte balance between the outside of these cardiac cells and the inside of the cells, right? So I'm not sure if you guys have covered any stuff like in like clinical laboratory medicine or anything like that, but basically when you're looking at your labs, what is a normal sodium? Well, a normal sodium is something like 135 to 145 milliequivalents per liter. That's in the blood, right? So you can kind of consider that to be the extracellular sodium concentration. So high sodium concentration outside of the cell. And then on the inside of the cell, there's actually relatively low amounts of sodium, but there's a high amount of potassium, right? You think about the extracellular potassium content of the blood being like 3.5 to 5 milliequivalents per liter. Compare that to sodium, which is 135 to 145. That's a huge difference. Well, where's all that potassium? Well, it's inside of the cells, okay? So that's important to understand. Sodium has a high concentration outside of the myocytes. Potassium has a high concentration in the myocytes, right? So what happens here? So you're going to initially see an opening of the sodium channels. And again, all this stuff is flowing along its concentration gradient, right? So things like to go from areas of high concentration to low concentration. The sodium channels open up, sodium floods into the myocyte, causing increase in potential, right? Because we see positive slowing in, so it makes it more positive. And then at a certain point, you're going to get the sodium channels closing up, okay? Once that occurs, you're going to get these calcium channels where calcium is flowing into the cell, which allows it to then have this little bit of a plateau phase here, right? So again, that allows for the nice sustained contraction. And then you're going to see, in order for the repolarization to occur, the big thing here are going to be these outward flowing potassium channels, okay? Potassium channels will open up, and that allows for the repolarization to occur. All those channels then close up, and then we're going to have what we call the sodium potassium ATPase pump that will help us to reestablish that resting membrane potential. So depolarization mainly due to sodium, inward flux of calcium causes the plateau, and then outward flow of potassium causes the repolarization. Okay, we'll get into more details on that. So if it doesn't make total sense, we'll see here. And again, you can actually see that on, if you were to look at an EKG, you would actually see this as a wave of depolarization and then the repolarization that occurs here, because again, it's happening in opposite directions from an electric sort of standpoint. Okay, so as I mentioned, that phase 4 is basically our resting membrane potential, where again, we're going to have more sodium on the outside and more potassium on the inside. And that is maintained by the sodium potassium pump. That's a really important pump that we're going to see how we can affect that with medications in just a little bit here. So as I mentioned, phase 0 depolarization, this is where those fast sodium channels are going to open up. So these sodium channels here normally are closed, sort of in an inactive state here. And then once that signal comes along, it's going to then cause them to open up. Sodium floods in, and then they go into an inactivated state here, right? This is important because when it's in the closed state like this, any electric potential can come along, can open these up, right? But when it's in the inactivated state, another action potential cannot cause that to open up. So it's in this state of inactivity where it's going to eventually be reset back to the closed state. Why is that important? Because that's going to give us what we call the refractory period, right? Or the start of the refractory period. You want to make sure that you don't have any sort of aberrant signal come in and cause one of these cells to fire off before they're ready, because that's how you get arrhythmia, right? So by giving the cell time where it's in a refractory period where it cannot recontract, that allows for sort of a normal synchronous sort of pattern of electrophysiology, right? That's what allows us to have a normal sinus rhythm. If you can affect this, and you can also affect how this depolarization is going to occur. So one of the big classes we're going to look at is actually going to be our sodium channel blockers, right? Sodium channel blockers will be the first class of antiarrhythmics we're going to see here. And so again, phase 0 is the depolarization. Phase 1 is basically where you're going to have the sodium channels close up. They go to the inactivated state, and then the calcium channels start to open up a little bit. So here we're going to see calcium channels are going to be open. Now remember, like I mentioned, sodium has a high concentration outside of the cell, potassium high concentration inside of the cell. What about calcium, right? You think about a calcium level, maybe you're thinking like 8 to 10 milliequivalents per liter in the blood. recall that within the myocytes, all that calcium is being sequestered in the sarcoplasmic reticulum. Don't forget that, because again, the heart's a muscle, just like skeletal muscle is. All that calcium is being stored there, and that's going to be important for the actual contraction, as we'll see in just a little bit. So anyway, what we're going to see here is these calcium channels are open, causing our plateau phase here in 2, and then we get the repolarization phase. This is very, very important, because this is another place where our drugs can really affect this, is by causing either a blockage of, usually a blockage is what the medication is going to do to prevent potassium from leaving. Now, we already talked about drugs that do this, right? We talked about drugs that can prolong the QTC. That's where we're going to see this effect here, is by actually blocking those potassium channels. So we can do that on purpose with certain medications. We use antiarrhythmics, or we could do that on accident with side effects of other medications, right? So you think about like your macrolides, for instance, or perhaps like your fluoroquinolones. It can extend the QTC by blocking the outflow of potassium here. But potassium is then going to flow outside of the cell along its concentration gradient and allow for the repolarization here. This is where you start to get into what we call the relative refractory period. Early on, you're going to get the absolute refractory period, where nothing can come along and re-trigger that cell to have an action potential. But as you get later into the relative refractory period, you can find strong enough signals can overpower that and cause another signal, another action potential to fire, essentially. Okay. So again, this is what we're seeing here. And then once we get to phase 4, that's where we have our resting membrane potential. This is sort of what's setting the baseline and allowing for the heart to kind of reset back to its initial state. So again, sodium flowing in during phase 0 depolarization. Sodium channels close, calcium opens and causes the plateau. Calcium channels close, and then potassium opens up to flow out, and that repolarizes the cell here. Okay, so hopefully you have a general idea. Now, what happens when you actually have within the muscle contraction itself? Well, again, as you have the action potential occur here, those calcium channels open up. And again, we already know some drugs that can block this calcium from coming in. So perhaps we're going to see this also can work as a antiarrhythmic. Calcium is going to come in. This allows for what we call this calcium-induced calcium release. Seems kind of counterintuitive, but calcium flows into the cell, which then triggers calcium to be released from the sarcoplasmic reticulum, and this then allows for the contraction of the myocyte to occur. Okay, this is again why calcium channel blockers affect contractility, because if you have less calcium flowing in, then ultimately less calcium flows out of the sarcoplasmic reticulum, and you get a weaker contraction, right? And then once we are ready to relax, that's where calcium is going to get sucked back into the sarcoplasmic reticulum. We're then also going to kick it back out of the cell with the help of a sodium calcium antiporter and the sodium potassium ATPase pump here. So we're going to look at it in just a little bit. So, and again, what you can see here, if you can kind of compare up the ventricular myocardial action potential along with the EKG, you can kind of see how this all lines up. Obviously, with your P wave, if you've done any EKG stuff, which again, I'm by no means the expert, but I can at least talk about the basics. When you see here the initial contraction in the atria is going to be your P wave, but again, I don't really care about that so much from a cardiac output standpoint. I'm more interested in this QRS wave, which again, QRS is that ventricular depolarization, right? And then remember, the T wave is that going to be that the repolarization of the ventricular myocytes while it kind of gets back to the resting membrane potential. Okay, and again, you're going to have what we call the absolute refractory period, right? Or again, no other signals can come along and trigger another action potential, and then the relative refractory period. So this is why QTC prolonging drugs are more likely to cause certain arrhythmias, because as you prolong that relative refractory period, that gives it a longer period of time where some extra signal can come along and then cause an arrhythmia. Normally like torsades is what we'll talk about with QT prolongation. But again, just to see how this all sort of lines up to cause your EKG, right? Your normal sinus sort of rhythm here. Now again, why don't you see atrial repolarization? Because it gets covered up by the ventricles, because it's such much larger muscle, so its signal is going to be much larger there. So that's the fast response cells, right? Those are your typical like atrial and ventricular myocytes and how they sort of act. I want to talk about the pacemaker cells, these slow response cells. They are going to have a little bit of a different action, because to them, like, they have an automaticity, right? They have a baseline sort of amount of heart rate itself. It has its own beat that it has. And so what we're going to see here is that what you notice is there's kind of a slant to this line here, where those the ventricular myocytes, it was just flat. That resting memory potential is completely flat. Nothing would cause an action potential to occur unless something came along and triggered it, some sort of signal, right? So what happens with these, though, is they have what we call sort of a leaky inward flux of ions that will get to a certain threshold. And when it gets that threshold, then it depolarizes, okay? So in the case here, we're going to see that phase 4, which is going to be sort of our resting state, so to speak, is going to be constituted by the activity of the sodium-potassium pump and then also the leaky sodium channels. So leaky sodium channels is going to allow slowly for the signal to build up, build up, build up, and then once it gets to that threshold, then we're going to find the calcium channels will open up and allow for a huge influx of calcium, so that increases the positivity there. And then we're going to see that the repolarization is going to again be affected by outward potassium, okay? So again, sodium influx will eventually lead to that threshold. Thresholds hit, then calcium opens up, and then will allow for the action potential to be generated. Will spread throughout the atria, will travel down through the ventricles, and cause us to have a nice sinus rhythm. Okay. So again, you can see how all of that sort of lines up between the two there. So I don't want to belabor these points too much because of the fact that you're going to get this in probably more detail elsewhere. But you can kind of see how these different principles of electrophysiology sort of line up to give you what you see on an EKG, right? So that way it kind of all makes sense when you're looking at it. It's not just a bunch of squiggly lines. It actually does make a sense to you. Like, why are we seeing these changes that we're seeing? And that'll be important when we get into the drugs as well. Okay. So as I mentioned, with the refractory periods, absolutely essential that we have these because we don't want extra signals to come in and cause another action potential to occur too early because our cells are not ready for that yet, right? We're going to see that that's not giving the ventricles time to relax, to refill with blood, and then to pump more efficiently, right? And again, absolute refractory period, no extra signal can happen here. It is just impossible because the sodium channels are still really in the inactivated state there. The relative refractory periods where things get a little more dicey. And so what you can see here is that by extending this as well, you're also going to be running into some potential problems for, for arrhythmias to develop here. So let's imagine you were looking at the force of contraction on the y-axis and time here. You can see if you had a normal action potential occur, you get the nice refractory period. Nothing else can happen. But towards the end is where you get that relative refractory period. And that's where you can end up developing these either early premature contractions, late premature contractions. So if you see someone have PVCs, for instance, premature ventricular contractions, it is because they're having that during that relative refractory period, right? Normally, that's not a great sign. That's usually telling you something's up here. Something's causing these cells to be extra excitable. We're getting these extra ventricular contractions. That's not good because, again, you want that sinus rhythm because that's how the heart works most efficiently. If you have the ventricles kind of firing off too early for some odd reason, that's not great for efficiency. That can lead to worsened arrhythmias that are a little less compatible with life. So, now again, how we measure the effect of a lot of our antiarrhythmic medications is based off the changes they have on the EKG, right? So I'm sure most of you are familiar with your different intervals here, and some of these I'm going to talk about to more detail than others. But for instance, like the QRS complex is really important because that is demonstrating ventricular depolarization, right? ST segments are going to be really important when you're talking about things like MIs and acute coronary syndromes, obviously. The T waves I also really care about because that's that repolarization. And so if that's being extended for some odd reason, then that's why you can end up seeing things like your QT interval get extended as well, right? So it's not just blocking those potassium channels that can extend this, but also if I block the sodium channels here and I extend out the QRS complex, that can again affect the QT interval as well. So you can see how there's kind of an interplay between all of these. Now let's talk about our antiarrhythmic drugs specifically. So hopefully everyone has a good sense of electrophysiology. Hopefully that wasn't too boring of a review for you guys, or maybe there's some new information there, who could say. But let's talk about our different drugs here and how they're going to be affecting the heart itself. Ideally, if you have a patient with an arrhythmia happening here, the ideal thing to do would be to fix the problem, right? So, are they having arrhythmia because coronary vessels are blocked up and they can't get any blood flow, so there's no oxygen, the tissue's getting ischemic? Well, send them to the cath lab, open up those vessels, and boom, it fixes your problem, right? It's because their electrolytes are out of whack. They have too much potassium on board. Well, get rid of that potassium if you can. Maybe they're a dialysis patient or something. So if you can do that, that's great. It may not always be the case, though. So barring that, the next thing we want to do is try to establish our goals of therapy. So do we want to terminate the ongoing arrhythmia, or do we want to prevent the arrhythmia from happening? And notably, we're going to see, can we decrease symptomatology, decrease frequency, things like that. There's going to be a target I'm going to talk about in a little bit, or going to be a topic I'll talk about called rate control versus rhythm control, right? That's going to be particularly with supraventricular arrhythmias like AFib and things like that. When I say rhythm control, that means we are trying to reestablish a normal sinus rhythm. So in this case here, we're talking about chemical means of converting someone back to normal sinus rhythm. It's called chemical cardioversion. Versus you can use electricity to do the same thing, right? You can defibrillate a patient, you can use electrical cardioversion, etc. We're going to focus on the drugs because, again, this is our pharm class. That's rhythm control. That's putting them back to a normal sinus rhythm. Rate control, though, is going to be more something we're going to talk about when we're trying to just keep the ventricles working at a nice, efficient rate. Even if the atria are not really beating like they're supposed to, that's okay because we're going to control the rate in the ventricles and keep cardiac output good. So we'll talk about that in more detail as we go on there. In terms of antiarrhythmics, we're going to see that all of them themselves can cause an arrhythmia, right? Because when you start to monkey around with the different, channels here, sodium channels, potassium channels, all of them themselves can induce arrhythmia. They can be quite difficult to treat if you do that. So we want to try to understand their mechanisms, understand what they're going to do, so that way we can try to mitigate any risk done to the patient. Okay. And again, things change over time. You're going to find that electrophysiology is a moving target, especially when you're having things like ischemia coming into play, causing tissue to die off. Remember, if you have a myocardial infarction and you kill off some of that tissue, dead tissue does not conduct electricity very well, right? Action potentials do not conduct very well through that tissue like normal healthy tissue would. It affects things like calcium concentrations. It affects repolarization rate. So a lot of things get affected by this, and so things change over time as well. So it's important to kind of take that into account. So how do we classify our antiarrhythmic drugs? We do it based off of their mechanism. So we're going to see some that are going to be calcium channel blockers, some are sodium channel blockers, and all that. I'm going to get more into details on these as we get into it. But half of these drugs we've actually already seen before. So that's kind of the benefit here, is that we've already looked at calcium channel blockers, beta blockers. So this is going to be somewhat of a review, but we're going to talk about them in their specifics for antiarrhythmic action. So what are the 5 sort of classes we're going to talk about? This is called the Vaughan Williams classification. It's pretty old school classification, but it still helps to sort of categorize this data here. But we have our class 1 antiarrhythmics. These are going to be our sodium channel blockers. Okay. We're going to have 3 subtypes under that. Class 1A, 1B, and 1C. They are going to differ based on how they're affecting the sodium channels. Some are going to be quick on, quick off. Some of them are very slow on, slow off. Some affect the open versus the inactivated state. We'll look at those details here in just a few moments, but they're all sodium channel blockers. Next up, we're going to have our beta blockers. They're going to be class 2 antiarrhythmics. And then class 3 is going to be the next new set of drugs we'll look at after the class 1s, where you're going to have things that prolong the repolarization period. That's going to be our potassium channel blockers. We have a couple of drugs there. And then we have our calcium channel blockers as class 4. Note that these are just the non-dihydropyridines. EHPs have nothing to do with this because, as we saw in the previous weeks, that EHPs don't really directly affect the heart. And then we're going to have a few miscellaneous ones, things like adenosine, digoxin. We'll talk about those in more detail. So in terms of indications, it can get pretty, you can get pretty lost in the weeds in terms of antiarrhythmics. And again, I'm not an electrophysiologist, so if you talk to someone who works in cardiology, someone who deals with this all the time, they can certainly probably give you a much better, deeper understanding of this stuff. But I'll talk about my experiences with these medications, how I've used them, mainly from an ER sort of setting, but we'll get into that. The big thing to note with this, right, and the thing I want you to focus on are these drugs going to mainly work just on atrial or supraventricular generated arrhythmias, or are they going to be more multi-purpose and they can affect both atrial and ventricular arrhythmias? Okay. When I get into the mechanism, that will make sense based on why each one will kind of work on one or the other. So some drugs work both on atrial arrhythmias and ventricular arrhythmias. That's mainly your class 1s and class 3s. while some are mainly just to affect supraventricular, so mainly generating the atrial sort of arrhythmias. So that's going to be your class 2 and class 4. If you have that down, then you're going to be pretty good, right? So if I say, oh, this person has ventricular fibrillation, meaning the arrhythmia is in the ventricles, then utilizing something that is going to be mainly affecting the atria or above the ventricles is not going to do you a whole lot of good. That's for the level of detail I want to get into in terms of this, but certainly you could do this for your whole career and get way further into the weeds in terms of that and get to the kind of the finer points. But again, this is the basics here. I want you guys to have just a basic understanding of this stuff. So let's get into our class 1A antiarrhythmics. Now, as I mentioned, sodium channels kind of have 3 states. There's the resting state where an action potential can come along and trigger them to open up. There's the activated state where they're open, sodium's flowing in, and then there is the inactivated state where they're in that sort of refractory period there, right? What happens if you introduce a sodium channel blocker, right? And again, these can be affecting arrhythmias both in the atria and the ventricles as well. Well, what happens when you do that is you're slowing that phase 0 depolarization, right? So the dotted line here is what happens when the drugs are introduced, the class 1A antiarrhythmic. The solid line is the normal rhythm you would normally see there, the normal depolarization. So as you can see, it slows down conduction and it prolongs the overall action potential here. Now, again, I'm not probably going to get too big into the weeds in terms of channel affinity. If you know if it affects open versus inactivated, unlikely to get that deep in the weeds in terms of testing. What I want you to know, though, is that they do block sodium channels, and what that's going to do to the action potential is slowing it down and prolonging it, okay? So again, if I had an arrhythmia where the cells were firing off too quickly, well, by introducing this, I can kind of slow things down and prolong the refractory period to allow the heart to sort of reset itself a bit, right? So it's sort of like just putting a brake on things and say, hold on, let's slow down this conduction a little bit to try to reestablish normal sinus rhythm here. Now, there's 3 drugs that fit into this category. I remember the class 1A antiarrhythmics as PDQ. Now, nowadays, some of you might know PDQ more so for chicken tenders. I was unaware of this when I learned this because restaurant was not around when I learned this stuff. But I know pretty darn quick. So that's how I remember the class 1 antiarrhythmics, the PD and Q. So the Q here is going to be quinidine. This is actually a isomer of quinine. Quinine itself is a really old school drug. Actually comes from the cinchona tree and is a old school anti-malarial drug. But we have quinidine, which is an isomer of that. And so this is going to be the first class 1A antiarrhythmic. Side note, because I probably won't talk about antimalarials with you at all, but quinine actually you can find in small amounts in tonic water. So assuming that COVID ever gets under control and people are allowed to go back out to these, apparently there's like places where you can go and just like gather and people listen to loud music and they drink alcoholic beverages. It's called a club, I guess. I've never really been to one, but so many people can never go to one of those again. Some people will drink something like a gin and tonic, and you'll notice under a black light it actually glows. Why does it glow? It's because of the quinine actually in there. So next time you are ever in that situation, that ever happens again, you can wow your friends with your knowledge of chemistry. Anywho, so getting into quinidine specifically. So again, what is this doing? It's slowing conduction, prolongs the refractory period, and again, just allows for this increased threshold for excitability. It takes a bigger signal to come along and actually cause an action potential to occur, right? Which that bigger signal hopefully is coming from your pacemaker cells as opposed to any sort of ectopic pacemaker elsewhere in the heart that shouldn't be there, for instance. And it's going to decrease automaticity, meaning the actual heart rate itself should be slowing down as well, okay? Now, there's some indirect actions it has which can affect some of these side effects we're going to see. So for one, it can act as an anticholinergic. We'll see some side effects related to that, and also can act as the alpha blocker, which we've seen some examples of those, like prazosin, for instance, that will actually cause effects on blood pressure, as we're going to see in just a little bit here. So what do we use quinidine for? And again, this is going to be applying to most of the 1A antiarrhythmics here. They're going to maintain rhythm with atrial fibrillation or flutter. So again, that's part of that rhythm control I mentioned, as opposed to rate control. You can also use it for ventricular tachycardias, or to convert, as I mentioned, atrial flutter and fibrillation, but this is pretty limited use. So that's that chemical cardio version that I mentioned there. So again, notice it can work for either atrial or ventricular arrhythmias because it's affecting these sodium channels, which are found all over in the atria and the ventricles themselves. That's why they're multi-purpose. Use it for supraventricular arrhythmias or for ventricular. Some things to note here is it is a 2D6 inhibitor, so that can be affecting things like codeine and morphine. May make some of these drugs more effective because you're not able to metabolize them as well, and they stick around for longer. So, for instance, you'd be more at risk for things like respiratory or CNS depression from morphine because it's hanging around for longer and levels are building up there. Now note, I mentioned for conversion of AFib or aflutter, again, this is not used too frequently anymore, but remember when the atria are sitting there and they're in fibrillation, just on this side, but what you're going to find is that they sit there and they quiver and the blood's sort of pooling there, and that's where you can get clots that can develop. So that's why anticoagulants are really important for use for things like atrial fibrillation to prevent stroke from happening there, right? Anyway, what are some toxicities? This is not a great drug because it does cause quite a bit of nausea, vomiting, diarrhea, which you can see. As I mentioned, they can induce their own arrhythmias. Any antiarrhythmic we're going to look at can do this. Hypotension due to the alpha channel blockade there, and some rare cases of thrombocytopenia. So we don't see it too often anymore, but you will still see occasionally. You know, some of my other students, when they hear about these drugs, are like, well, why in the heck would we ever prescribe these medications here? Sometimes you have to because there's not really any other good options within the category. I see this more so, especially on the cardiac unit where I work, pediatric, cardiac critical care, because these are kids that have like congenital heart defects. They have actual structural issues that necessitate use of some of these drugs here. So again, you still see them occasionally, but that's why it's good to know about them. If you see someone who's on them, even if you never prescribe it, you at least are familiar with it. Now, there's also this something called synchonism, and this has to do with that cinchona tree that I mentioned that quinine comes from. But it's this triad of symptoms here that are very sort of specific to quinidine and quinine. And again, this is a good board-style question. If you ever see this, you can automatically assume it's referring to quinidine. That synchonism refers to having tinnitus, dizziness, and blurred vision, right? So very unique to this particular drug here. Now, again, some of the other things you can see is quinidine sudden death. Doesn't sound like a very good side effect, I imagine, for most people taking this drug here. A lot of that is related back to the arrhythmias, right? Because it is prolonging that whole action potential there, including the refractory period towards the repolarization phase. That's why you can end up seeing things like torsades that can develop here. And that's what leads to that sudden death, where basically someone's going along, they're fine, and they go into an arrhythmia, ventricular arrhythmia, and they pass out and die, right? So that's something you can see rarely, but it can happen. This is why electrolytes are really important to watch out for, because you don't want to screw up people's electrolytes, because that puts them at risk for some of these arrhythmias, okay? One other thing I wanted to note here is, again, when you're looking at the slowing here, remember what this is affecting on the EKG. By slowing the depolarization, this widens out your QRS, right? Because it takes longer for the actual depolarization to occur. When you extend out here on the repolarization phase, this prolongs the QT interval, right? So you can see how if you were to give this to a patient, you'd have both extensions in the QRS interval and in the QTC, okay? That's what you would see on the EKG, basically. Okay, so that's it for quinidine. The P in the PDQ here is a drug called Procainamide. This one I do see fairly commonly on the cardiac unit here, and typically given as like an IV continuous infusion to control arrhythmia. Some benefits with this over quinidine is it doesn't really have too much anticholinergic activity and no real alpha blocking ability, so it doesn't cause the same kind of hypotension as what you would normally see. What's interesting with this one, though, is it undergoes acetylation, which, if you recall, we talked about another drug that undergoes acetylation, that was hydralazine. So you're actually going to see some similarities here. But basically, it gets acetylated into this product called Napa, which actually has class 3 activity, which we're going to get into a little bit later on. And so what that means is you can have people that are slow acetylators, people that are fast acetylators. And so people who are quick acetylators, they actually form more of this Napa, which itself could be therapeutic, or it could actually be toxic. It could actually lead to arrhythmia if that QT prolongation is not what we need, which we'll see class 3s typically do. Slow acetylators, though, they're going to have sort of another problem where they don't get rid of the original procainamide quick enough, which can lead to, again, arrhythmia, or can lead to some other things, as we're going to see here. So a little bit of hypotension, probably less than quinidine. Again, you can get that lupus-like syndrome. So this is just like with hydralazine, right? We saw that typically like in Caucasian patients, females, high dose, long-term use. Those people tend to have higher buildup of the drug. They tend to be slow acetylators. Same thing happens here with procainamide. So you can see that same thing. Again, it's always good to know what kind of drugs give you that lupus-like rash, because that is a good pimping question on rotations and on the board as well. Again, torsades can happen here. This is all related to QT prolongation. Rarely can you get some bone marrow suppression. You wouldn't want to watch a CBC while patients are on this. And again, probably won't see it used orally in the long term because it's poorly tolerated based off all this stuff here. But if you're using it in a pinch in the cardiac ICU, it does work out fairly well. And then the last one here in class 1 is Disopyramide or Norpace. Similar activities to Quinidine, even more anticholinergic actions, right? So you can see things like constipation, you can see dry mucous membranes, all the stuff that goes along with anticholinergic sort of effects there. And it'll have some negative inotropic effects that can actually diminish some of your contractility there. What you're going to see this used for is typically for either ventricular arrhythmias or supraventricular arrhythmias. Like I mentioned before, the class 1 antiarrhythmics can be used for either. Perfectly reasonable there. Similar side effects, what you're going to see with Quinidine, but you don't get the same synchronism. You don't see that there for sure. And again, due to this decreased contractility, that's not going to be good for patients with heart failure, right? Because we know they already have an issue with diminished contractility in the first place. That is something you would want to watch out for. All right. So then switching gears and going to the class 1B antiarrhythmics, this is mainly going to be doing, again, it has a higher affinity for the inactivated sodium channels rather than the open ones. And so this is going to be working to actually shorten up phase 3 a little bit. So this is going to have a very particular use case, as we're going to see here in just a few moments. But basically what it does is it decreases the automaticity of ectopic foci. What do I mean by that? Basically, what if you had something like, say a patient has a heart attack, and they start to cause ischemia in the tissue, and that leads that tissue to then start kind of generating its own action potentials, right? Or sometimes what you'll see in the heart is you can have sort of a circular type of arrhythmia pattern that develops as a result of slowing of conduction due to like ischemic tissue and stuff. And so basically what you're going to see here is that this works better in ischemic tissue where those ectopic foci are more likely to develop. And so you decrease their automaticity there. And so by blocking those inactivated sodium channels, you actually end up leading to that ischemic tissue functioning more similarly to normal tissue. So you actually shorten up the refractory period to some degree here. So a very limited use case, mainly in MI, is what we're going to see in those cases there. There's only one drug I'm going to talk about here, I think. Yeah, only one drug. And this is actually lidocaine. Now, some of you may be familiar with lidocaine being used as a local anesthetic. It's pretty good for helping to numb up tissue. And actually, the way that it numbs nerves that would carry painful sensations, it does the same thing to the heart, so all blocking sodium channels. And so there's a couple uses for this. We're mainly going to find lidocaine being utilized for ventricular tachycardias, VFib, premature contractions, things like that, generally in the context of acute MI. Sometimes it can be used for something called Wolff-Parkinson-White, which I'm not going to get into. It's kind of outside of our scope for today. But this is where we used to see lidocaine being used all the time, was basically during MI, because that's when you get that ischemic tissue that we were talking about there. So when doing this, local anesthetics like lidocaine are typically given, infiltrated into the subcutaneous tissue, stuff like that. If we're doing it for an antiarrhythmic purposes, lidocaine is given IV, generally as a continuous infusion here. And again, working better in that ischemic tissue, shouldn't really be affecting the normal tissue too much. That's kind of its wheelhouse as an MI. And again, this is not going to be effective for atrial arrhythmias. That's the one exception out of the class 1 antiarrhythmics. This is the only one that doesn't really work for atrial arrhythmias. So the other big problem with lidocaine is that, again, as I mentioned, it affects nerves, right? It affects the ability to sense painful stimuli. It can actually do that too in the CNS and block sodium channels up there. So if you have a patient who starts to complain about like a metallic taste in their mouth, or you start to see they develop nystagmus, which you can do, having them follow your finger and their eye movement, that's not a good sign, right? That usually means you have too much lidocaine on board and can lead to seizures, which is something we do not want to have on top of an arrhythmia or an MI if they're already experiencing that, right? So watch out for things like renal insufficiency, hepatic insufficiency, because that's really going to extend the half-life of the drug, and that's not going to be great for your patients there, right? So one thing is just to watch out for. Okay, so moving into our 1C antiarrhythmics here, this is going to be 2 drugs. It's going to be Flecainide and Propafenone. And actually, I was just at the hospital yesterday, and I saw one patient on Flecainide. So these drugs do get used occasionally. So what are these drugs? They actually work pretty similar to the class 1A antiarrhythmics here. They slow down phase 0. They're working on those open channels there, but very, very slow dissociation. So you can see here this depolarization rate is much slower than what you would see with even a 1A antiarrhythmic there. Okay. Again, it's going to be affecting normal heart tissue just like the 1As do. Again, the 1B effect was really sort of a unique thing to that group. Now, Flecainide and Propafenone are going to be the two drugs in this category here of the 1C. And again, because they're slowing down that sodium channel influx, you're going to prolong the PR, QRS, QT intervals, right? The whole thing's going to be affected there. And again, this one is sometimes used to do things like treat premature ventricular contractions or in order to keep patients who have like AFib in normal sinus rhythm. So this is, again, a means of rhythm control to try to keep people in a normal sinus rhythm here. So what we would use it for would be things like life-threatening ventricular arrhythmias, supraventricular arrhythmias, because again, it's going to be pretty multi-purpose there, it can work for both, or used in patients without significant structural damage to the heart, because again, things get much more complicated. Sometimes you have accessory pathways that can be affecting their sinus rhythm, so got to be really careful with those patients there. And again, outside of our scope for today's purposes. What kind of side effects can we expect to see here? Some blurred vision, tremor associated with this. Again, ventricular tachycardias are more likely with these. And actually what we end up finding is that for a while we used to do something called pill in a pocket, where basically patients would have sort of like a as needed prescription for drugs like Flecainide, where if they felt themselves going into AFib, because frequently you can feel that, they would go ahead and just pop one of these, and hopefully that would put them back into normal sinus rhythm. Unfortunately, though, we did find increased mortality with this. So not used for that purpose too frequently, but you will still see these drugs being used, especially for people like congenital heart defects or if they've had open heart surgery, things like that. Other issues include things like bronchospasm, so it's probably is not good for asthmatic patients, thrombocytopenia, so watching your CBC, all those things you want to look out for. And again, not great from a side effect profile, so again, you're not going to see it used too frequently for otherwise healthy patients. Propafenone or Rythmol is going to have similar activity to Flecainide, but it also gets some additional beta blocking activity, so it can actually slow down heart rate, be a negative chronotrope, right? And similar side effects of what we're going to see there. Bronchospasm, mainly due to beta channel or beta receptor blockade there. And again, things like agranulocytosis, anemia, watch out for that. And of course, having beta blocking effects will cause contractility issues as well, so bad for patients with CHF. So again, you're like, well, who would ever prescribe these? Again, you're probably not going to be the ones prescribing these. Probably going to be your cardiologist, your electrophysiologist. Not to say you can't work in cardiology, but again, these are very special use medications. What I want you to know about these, though, is if you see a patient who, like, say, comes into your urgent care clinic, to the ER, wherever you're working at, and you see that they're on one of these, this should be like a red flag. You should be doing some extra investigation. Okay, why are they on these drugs? Are they being monitored appropriately? Are they having side effects from these drugs? Be able to kind of look into this stuff when you see this, right? This should be kind of a red flag set of medications here. Okay, so class 2 antiarrhythmics, this is pretty easy because we already covered the beta blockers, right? So now looking at their use here, these are not going to be good for treating ventricular arrhythmias because how they're working is to slow down conduction. So they're decreasing automaticity. So say, for instance, you have someone who's an AFib, right? They're an AFib, they have very rapid contractions of the atria there. The problem you run into is that sometimes you can get, especially like A-flutter, for instance, which is a slower rate, but if that rate starts to get communicated down into the ventricles can only handle so fast of a rate. Once they get going too fast, they stop being very efficient because they don't have enough time to allow blood to flow in, and they can't contract for long enough to cause the blood to flow out. That's when you get into unstable arrhythmia, is when the ventricles are not able to maintain cardiac output. So what do we do to prevent that really rapid signal from the atria going down into the ventricles? Well, you can do that a couple of different ways, and one of which is going to be the beta blockers, right? And so this is a form of what we call rate control. Now, this is not going to put a patient back into a normal sinus rhythm, but it will control the rate to keep them at a stable cardiac output. So on the EKG, you may not be able to find those P waves very easily because the atria are just sitting there quivering, but your QRS T wave should be golden. They should be fine, assuming you're keeping a good steady heart rate. So the prolonged AV conduction, they decrease phase 4 depolarization, as you can see here, and they're going to decrease automaticity. So heart rate should be slowed down here. all of the same stuff that we learned before is still applying here, right? So knowing the difference between non-cardioselective versus cardioselective beta blockers versus the third gen, be able to realize all those different activities there. Some drugs might be a little bit better suited for purposes of arrhythmia specifically. For instance, like propranolol has what we call a bit of membrane stabilizing activity, where it can actually try to decrease some of this area of automaticity in some of these other tissues. Again, it's a minor effect. The biggest thing here is it's slowing down AV nodal conduction, right? Slowing down the rate traveling from the atria down into the ventricles to keep the ventricles going at a nice efficient rate there. Okay. So as I mentioned, primarily what we're going to use these for is supraventricular arrhythmias. Occasionally use them for a ventricular ectopic beat, but this is not a common occurrence here. And then MI, obviously we talked about its use there in MI because it does help with mortality and whatnot. Again, watch out for things like contraindications, like patients already have heart block, or if they are in heart failure, decrease contractility. All that stuff there still applies here, right? Just nothing really new from that standpoint. And recall, any beta blocker will serve this purpose for an arrhythmia, whether it's cardioselective or not, because it's mainly the beta 1 receptors in the heart is what we're actually targeting here. So just be aware of that. Occasionally what we'll use from like an ER standpoint is something called Xylocaine. This is actually a very short-acting beta blocker that we can use via continuous infusion IV, which is really handy because as we're giving it, if the heart rate's still too fast, pump up your dose, dial up the dose, and it should help that out. If the heart rate's too low or blood pressure is too low, dial down your dose, and it's very titratable, which is very handy from that standpoint. All right, class 3 is the next new set of drugs we're looking at here. Basically, these are purely potassium channel blockers. These only thing they do is prolong the repolarization. So if you notice here, they don't affect that phase 0 depolarization because they don't affect sodium channels. So they block potassium, prolong the refractory period here. And what this is going to do, mainly on the EKG, is prolong QT. Okay. And again, QTC is corrected based off of the heart rate. So those numbers are different, but it's usually based off the patient's heart rate. So this prolongs the refractory period and prolongs the duration of the action potential. So again, if you have like an ectopic foci or something that's firing off these extra signals, this is going to help suppress that because it's extending out that refractory period and preventing these cells from firing off a new signal too early. The classic drug out of this category is called amiodarone. And so this is kind of interesting because it's actually an analog of thyroid hormone. This is actually going to be important for some of the side effects, as we'll see here. And so this is pretty general purpose antiarrhythmic. And in fact, in most cases in the ER, this might be one of your first line go-to means of treating an arrhythmia, especially like a ventricular arrhythmia or someone's in a cardiac arrest or something like that. This is a common drug you're going to see here used. So if you look at your ACLS guidelines, amiodarone's like top of the list in terms of, other than like electricity to defibrillate a patient, obviously. But patients with VFib, VTAC, this is like the go-to drug. So you'll see a lot of use of amiodarone in cardiology, in the ER, etc. This is a pretty good drug. There are some downsides though, as we will see. So what we can see with this drug here, if you notice as well, it has a really long half-life, 40 days on average, but it can extend anywhere between 26 and 107 days. Now, if I have a patient who is in VFib, for instance, and they have no blood pressure currently, and they're actively dying, I guess we're all actively dying, but this patient's doing it much quicker than others. What you're going to see here is that if I were to try to give amiodarone at a normal dosing pattern and wait for that patient to get to steady state, if you recall how long it takes to get to steady state, it's like 4 to 5 half-lives. If I waited 4 to 5 half-lives, I'd be waiting 200 days basically for this patient to get steady state. He'll be long dead by then, right? How do we get around that? Well, basically what we can do is use loading doses. So this is a really good example of using a loading dose to get the patient up to steady state right away, and then you follow that up with a continuous infusion. Hopefully you're controlling the arrhythmia and the patient's going to live, right? So again, we use this for recurrent ventricular tachycardia for ventricular fibrillation. We can also use this for atrial arrhythmias as well, so like control of AFib, A-flutter. This is, again, a means of rhythm control as opposed to rate control. Beta blockers, slowing down that conduction between AV node to the ventricles, that is a form of rate control. This is a form of rhythm control because you're trying to maintain normal sinus rhythm with these drugs here. So amiodarone itself is actually kind of interesting because not only is it a pure potassium channel blocker, but it also does a lot of these other things as well. So it's blocking some sodium channels, it'll block calcium channels, alpha and beta receptors. So it does all these different things here, which again can lead to its clinical effects, but also lead to some toxicity, as we'll see here in a few moments. So hypotension is a big one. Obviously, if patients are in a life-threatening arrhythmia, they have no blood pressure to begin with. So again, that's something that could be complicated there. Some of these things are not going to be apparent until they've been taking them for years, which you might find for some patients that might be on these drugs for decades. So things like pulmonary fibrosis, right? This is not going to be for someone who's acutely getting it in the ER, but for patients who've maintained it, on it for decades potentially. Again, PFTs would be something you'd want to watch out for over time if they're on this. You see things like neuropathies and muscle weakness. Interestingly, over time, the drug will build up in the skin, so you get a blue-gray skin discoloration, right? Pretty odd, unique sort of side effect there. You see eye issues that can develop due to corneal deposits, so you would want to check for visual acuity over time. And then interesting as well, because this is going to be a analog of thyroid hormone, it can both cause hyperthyroidism or hypothyroidism. So you do want to watch out for this. Make sure that you are following their, TSH levels, T3 levels, things like that. See where they're going, especially if they're complaining of any symptoms that are consistent with either one of these. Okay. Then a lot of drug interactions that can happen here, mostly due to either pharmacodynamic interactions. Obviously, if you put this with a beta blocker, that's really going to suppress cardiac output pretty significantly, things like that. So you do want to be watchful for drug interactions anytime you're adding amiodarone onto something else. Now, whereas with amiodarone was kind of wide ranging in terms of its activities, affecting a lot of different types of receptors here, the phthalate or Tecousin is just a pure potassium channel blocker, right? And again, remember what happens when you block potassium channels, you prolong the QT interval, right? And again, what does that possibly lead to? Torsades. So this is a really big risk for this drug, is causing patients to go into torsades. And actually, if you recall, there are some drugs that have such significant side effects, they get what they call a REMS program. It's mandated by the FDA, and that is a risk evaluation and mitigation strategy. Well, the phthalate or Tecousin actually has a REMS program associated with it, because we know the risk for them developing torsades is pretty high with this drug, because we know it's going to prolong the QT, because that's all it does is block potassium channels. You have to make sure that their electrolytes are in place. Make sure the potassium is in range, calcium, magnesium is all good in range. Make sure the renal function is not too depressed, because this actually undergoes pure renal elimination. So if they have a hit in their kidney function, levels of Tecousin are going to build up pretty quickly. It can lead to life-threatening arrhythmia. So very limited in terms of availability, really only to cardiology would this be utilized, right? But again, if you're working in cardiology, or if you see patients who are coming in on this, you'd want to be aware of that. So out of the way, because that window's blocked up. So Odalis was saying that would you not also see torsades with amiodarone? That is a risk for sure. That is a bigger risk with something like dofetilide, just because it's a pure sort of QTC extending drug there, versus amiodarone having kind of multiple actions. Savannah was saying, does that onset of torsades occur rapidly after administration of the drug, or is it over a time kind of reaction? That's a good question. So, and my wife deals more with this than I do. She does a lot of Tecousin counseling in the hospital. She works in an adult hospital, whereas I mostly work with peds. So for her, when she's doing this, she has to make sure, from the pharmacy standpoint, that sort of all these different check boxes have been ticked to make sure that they're good candidates for the drug. So initially, you're looking to make sure the electrolytes are good, renal function's good, and all that. And then they're in the hospital when they initiate this, because you want them to be on an EKG to see what the change is, right? So, normal QTC can range from person to person, but let's say 440 milliseconds. 440 milliseconds is pretty typical. So if you start them on this, you will see an extension of that, right? That's just known, because that's what the drug is doing. That's what you want it to do, is extend the QT to some degree. But there are certain cut points that they start to get like above 500 or 550. That's where your risk for torsades goes up. So could this happen with the first dose? Potentially, especially if they were already bad candidates to begin with. Or it could happen over time, where maybe they were looking pretty good in the hospital. They go home. Maybe their electrolytes are not being really taken care of. Maybe they're malnourished or something. Perhaps their kidney function takes a hit. You can see it down the road. So really, anytime they're on this, it could happen. That's why you want to have very close follow-up on these patients here. And again, if I'm treating AFib for this or something like that, that's why frequently it's just easier to use something like a rate controller, like a beta blocker or calcium channel blocker, because you're not going to run into issues like this. No one's going to have a sudden death event due to a beta blocker typically, or at least the risk is much lower or something like that versus something like Tecousin. Tecousin, I feel, is kind of like playing with a loaded gun almost. So it's good for what it does, but you don't want it to go off in your face for sure. So you gotta be really careful with that. But anyway, you're like, well, why would anyone ever use these drugs? Because they have their places, you know, they have their specific niches where they're going to be kind of most effective for a particular patient. So again, if I worked in cardiology day and night, I could probably tell you more details on that. But again, this is the kind of overview, right? Some of these drugs have a lot more experience with than others. Like I use amiodarone quite frequently, diltiazem, verapamil, beta blockers, you know, all these used very frequently in the ER sort of setting. Now, Sotalol is kind of weird because you're like, wait a second, Sotalol, that's a beta blocker. That should be class 2. Well, actually, Sotalol is the odd ball in this group here. Sotalol itself, while primarily a beta blocker, also does have some potassium channel blockade along with it as well. So we will typically consider Sotalol to be a class 3 antiarrhythmic here. So again, QT prolongation is something you would not normally see with the beta blocker, but you can certainly see with Sotalol because of the activities here. All right. Again, you typically use for AFib, a flutter, ventricular arrhythmias. Same thing you would use amiodarone or Tecousin for. I will tell you, like in an emergency sort of setting, though, amiodarone is probably the one that most people are most comfortable with and will probably use most often. I'll give you like a clinical example here just a little bit to kind of show you like the different drugs we can use in their different settings. So again, be aware of Sotalol because it's a non-specific beta blocker. You can't see bronchospasm, torsades, all that kind of gets wrapped up with this one in particular. On class 4s, another easy one because this is going to be our calcium channel blockers, and primarily these are going to be your non-dihydropyridine, so just verapamil and diltiazem. Okay, again, the activity in terms of what they're doing to the heart is almost identical to what the beta blockers are doing, just doing it via a different mechanism, right? So these are going to be affecting that inward flux of calcium during the depolarization. But be aware they're also negative inotropes. While they don't really decrease or treat a ventricular arrhythmia, they don't really work on the actual electrophysiology of those cells in that way. They do decrease the contractility, right? That normally happens there. So just be aware of that. Again, these are better for supraventricular arrhythmias, not going to be good for ventricular arrhythmias, just like the beta blockers, okay? And again, everything that we covered before is still applicable here. So remember things like the CYP3A4 interactions. Recall the side effects you can see with these chronically, things like the constipation, peripheral edema, all of that is still applicable to these drugs here. It's just you're using them in a different context, right? So again, they're suppressing AV node, SA node. These typically are going to be more effective in like really active tissue. So that's why like for AFib, A-flutter, these work pretty well to try to prevent that really active fast signal from being transmitted down to the ventricles, leading to that sort of inefficient pumping. So atrial fibrillation, PSVT are frequent uses for these drugs here. And again, the same sort of contraindications apply. So if a patient already has a heart rate of 40, probably don't want to give them a non-dihydropyridine calcium channel blocker, right? They have heart block or something like that. So same contraindications here as you would see with the beta blocker. But remember, if I have an asthmatic patient, I don't really care about giving a non-dihydropyridine to because I'm not worried about their asthma from that standpoint, for instance. So let's talk about our miscellaneous antiarrhythmics here. The first one I will talk about is going to be adenosine. Adenosine is a really cool drug. So I don't know if any of you have experience in the ER, perhaps as a scribe or something, or as EMT. If you ever see adenosine being given, it's pretty wild. I recommend you get to see this if you're on rotations. Basically, you know, so if you think about like the body as a big computer, right? Obviously the brain would be like your CPU. The heart's gonna be the power supply, you know, kind of keeping everything running. Adenosine's kind of like pulling the plug on the computer, turning it off and turning it back on. Very cool drug when you see it given. Basically what this does is it activates adenosine receptors on the heart and basically shuts everything down. Basically all these potassium channels in the atria open up, blocks those calcium channels. So basically when you give this to the patients, all the cells get hyperpolarized and essentially the patient just flatlines for like 2 or 3 seconds. And you're like, wow, that sounds really dangerous. And it is pretty crazy when you see it. And you know, kind of everyone has a bit of a bated breath while that flatline occurs, but then hopefully as adenosine gets metabolized, because if you look, the half-life is like 10 seconds, so it gets eliminated very quickly, you then allow for the heart to come back online, and hopefully it's going to be back in normal sinus rhythm. So pretty cool to see, because basically you'll have a patient, and this is primarily and mainly just used for PSVT, so paroxysmal supraventricular tachycardia, where the patient's like tacking away at like 180 or something like that. Again, the fear is that supraventricular signal is going to get sent down to the ventricles, and they're going to get unstable. If the ventricles beat too quickly, they're going to not be very efficient, and that's where they get unstable. Their blood pressure goes out of whack. That's where you got to be really careful there, right? So anyway, adenosine is able to sort of help reset the whole heart there. So PSVT, sometimes Parkinson White will use this as well. And so basically what you're going to do is you have a patient who's in PSVT, they'll be tacking away at like 180, 200, like sometimes in little kids you'll see that. Typically when people are in PSVT, you try to have them Valsalva down to try to suppress that really rapid signal. So you have them like, try to bear down, or have them breathe through a straw, or put, ice packs on their neck or something like that. If it's not working, then adenosine gets used here. And so basically you put them on a continuous 12-lead EKG, monitoring the EKG, that you're sitting there and seeing them just tacking away, and all of a sudden you give the drug, and then you see nothing for a few seconds. Patient's going to feel real weird while that happens, and then a couple of seconds later, hopefully they'll go back into normal sinus rhythm. Sometimes it doesn't work, and they'll go back into PSVT, but that's the goal, is to go back to normal sinus. So again, a lot of side effects associated with this, but fairly quick acting. So they're going to feel that burning in the chest, or shortness of breath. Some people describe sort of an impending sense of doom feeling, which is actually a side effect that some people report. So impending sense of doom. I'm sure most of you guys feel that right before my test, so I guess I have the same side effect. But point being, very fast acting drug. Now, the big thing with this one is that the administration of it is extremely important. And so this is something I like to stress to you guys, is that if you don't give drugs appropriately, then you can't really blame the drug for not working, because it's more of a issue with the provider. So adenosine having a half-life of like only 10 seconds, and a lot of times patients are coming in, they don't have a nice central line that's dumping drug right into the vena cava. They frequently have like a peripheral line at best. A superficial, peripheral line. And so what happens is you have to flush this drug and get it to the heart as quick as possible, because if you don't, then it's going to degrade down. So what that means is if you just kind of push it leisurely into a peripheral vein, by the time it gets to the heart, it's all degraded. It's gone. So we have to develop this little contraption, basically, where we get a three-way stopcock that allows us to push the drug very quick. So I can maybe draw you a little picture here real quick to show you kind of what this looks like. So if you recall, a three-way stopcock, I don't know if you guys ever use these during your maybe chemistry classes or something like that. Basically, you have three ways that the fluid can go here, right? And again, this is a pretty poor picture, but you get the idea. And so you can hook up three different things to this, and you have usually a little dial that will kind of guide which way the medication is going. And so basically you're going to have drug on this end. You're going to have a saline flush on this end, so just normal saline there. And then the patient's going to be on this end. And so basically you want to make sure that you can flush the drug as quickly as possible. You slam that in. And then you're going to flush it behind with usually 10 mLs of normal saline behind that. And that will help to push the drug back to the venous system, back to the heart as quick as possible. So I'll have a lot of times where people do this incorrectly, or the worst thing you can do is to not understand how a stopcock works, and they'll have the knob here pointed towards one of the directions, which is going to keep it from actually flowing. So make sure it's in the right orientation there, and they don't give it fast enough. And so they say, well, the drug didn't work. It's really because you didn't give it right the first time. So a big kind of pitfall that I see with a lot of people trying to give, especially if you're like in a nervous, kind of high intensity situation where you're worried about the patient becoming unstable. So it's something you'll see there. So if you ever got the opportunity to see, it's pretty cool. If not, wait for ER rotation and see if you can get a gander at that. Switching over to talking about digoxin, we've talked about this before in terms of its use for CHF. Obviously, here we're going to be using it more for AFib. This is not typically used for AFib alone. It's going to be better for patients that have the combo of AFib and CHF most often. But again, remember, it's going to be affecting those sodium-potassium pumps, slowing that down. That does increase contractility and typically will slow heart rate down. So usually it's going to have a negative chronotropic effect, also because it's increasing parasympathetic tone, right? That also kind of slows things down. With more acetylcholine on those muscarinic receptors there. Now again, bradycardia is usually one of the most common arrhythmias you're going to see here with digoxin. But again, that could be a good thing if you're trying to slow down conduction for those patients with AFib. Savannah's asking, dumb question, I doubt that. Are you slamming the adenosine into an artery then like a PICC line, or can you do this through a vein and get the same effect? So, good question. I want to make a distinction here. And again, this may not be something that will become apparent until maybe like you're working out there in the field on rotations or something. It is extremely rare that you ever give a medication intra-arterially. Okay. If you think about why that is, that kind of makes a sense, because if I were to infuse a drug into the artery, it has to go all the way through to wherever it gets switched over to the venous system and then get transported back to the heart before it kind of gets pumped out into the arterial side where it can kind of spread throughout the body. So you're kind of limiting yourself in terms of the drug being able to affect the person systemically by giving it to an artery. So I'm trying to think of any instances of a drug being given arterially. Like maybe you'll do some heparin just to keep the line patent, but other than that, you really don't. So, but you mentioned a PICC line. What is a PICC line? It's a peripherally inserted central catheter. PICC lines are venous by nature, but basically that catheter is going to be inserted, whether it's in femoral vein or elsewhere. That catheter is going to be dumping out into the vena cava essentially. So they go to the IVC. But by doing that, then all that drug dumps out right into the right side of the heart, where it can be pumped around and get out into the arterial side very quickly, as opposed to if I was giving this into like the antecubital vein there. So big distinction there. So would it work better if it was going through a PICC line? 1000%, right? But most patients who are coming in off the street with PSVT don't have a PICC line, because who has PICC lines? Well, usually people who have chronic medical issues, they have a port placed or something like that. But that's not typical patients. So frequently that's not going to be an option for us. But yeah, it's a very good question. And again, the logistics of giving medications is something we don't probably talk about enough, but I like to bring that up wherever it is appropriate. Anyway, so getting into digoxin again, yeah, hopefully that does make us sense. And again, getting an intraarterial line is much more difficult than a vein. It's just a whole lot of logistic issues there. But anyway, so again, probably not going to see digoxin used by itself as an antiarrhythmic. More often, if it's doing dual mechanisms, so if someone with AFib and CHF is on it, that makes sense. But be aware, you have to watch out for things like potassium levels. You have to watch out for the renal function. Remember all the side effects we talked about that are pretty particular to digoxin, like the xanthopsia and all of that. So be careful with this one if you see someone on it. Again, perfectly reasonable drug, but you just have to make sure you're monitoring pretty closely there. So I see digoxin used quite frequently up in the PEDS critical care unit, or the cardiac critical care unit. It just depends on the indication for these patients here. And the last drug I'll talk about here is magnesium sulfate. So this has a pretty wide range of uses. You can see magnesium being used for status asthmaticus. You can use it for preeclampsia, so it can treat blood pressure in pregnant patients. Here we're using it specifically for torsades. And so if you walk away with nothing else from this lecture at all, you should at least know that magnesium sulfate is a treatment of choice for torsades, because I guarantee you that's going to come up on some test. Some preceptor is going to ask you on the boards somewhere. You're going to get asked, what's the treatment of choice for torsades? You're going to say magnesium sulfate. Pretty easy there. But again, if you think about it, it kind of makes sense, because magnesium itself kind of acts a little bit like a calcium channel blocker to some degree. So it's able to kind of treat that particular arrhythmia. It just happens to have pretty good activity against that. What other side effects might you see? Flushing, can see some hypotension associated with that, maybe bradycardia. But again, probably better have that than a patient being in torsades, because that rhythm is not really compatible with life, as it turns out. So that's it for this section. So let me walk you through a clinical scenario that I ran into a few years ago, just to kind of see how we utilize these drugs in different ways here. So let's imagine we have a 10-month-old who's coming in to the ER. Kid is not acting right. Parents just say, hey, something's wrong with my kid, and if you're a parent, you kind of know that. You're kind of like, man, something's off here, right? So these parents had very good intuition. They said, my kid's not acting right, so bring him into the ER, right? Find out it's because the kid is in PSVT. Kid's tacking away at like 180, right? 180 beats per minute. And so again, it's a 10-month-old. So again, a lot of cooperation is not going to be good to be like, okay, bear down. Like 10-month-old's not going to know what that is. So we do some things, try to do some physical things to try to have this patient vagal down, either have them, you can try to get them breathing through a straw. It doesn't really work so well. Try ice packs and things like that. Not working. So what do we do, right? Right now, the patient's blood pressure is stable, but for how long? How long can that ventricle keep up at that really rapid rate? And so first drug we go to is PSVT. So we go ahead and get our adenosine on board, right? So we give the adenosine, get the first dose, we give it appropriately. You see the heart rate stop for a couple seconds, comes back right back into PSVT. Okay, try a bigger dose. So go to the bigger dose of adenosine, same thing happens. Okay, so this is not going to be effective. So we're saying, okay, so the patient, we can't terminate this rhythm right now. We can't get the patient back in a normal sinus. What could we do? Now, could you shock the kid back into a normal sinus? Yeah, but we typically hold off on that until they become unstable, meaning once they have they cannot maintain cardiac output and their blood pressure starts to go down, and basically they're heading towards cardiac arrest. We're not there yet. So what can we do then? So, well, what if we could slow down that conduction, that really rapid conduction from the atria down into the ventricles? So what could we do then? Well, let's use a class 4 antiarrhythmic. We're going to get diltiazem on board to try and slow down that rate. So we get diltiazem on board, use as a continuous IV infusion, and it does help out to some degree, but it doesn't really get things to where we want it to be, right? When we give too much diltiazem, we're about looking at the blood pressure, so not really being all that effective. So we're like, okay, well, what else could we do to try to terminate this arrhythmia, right? By now, we've got cardiology down on board. We've got the ECMO team on call. If you guys know what ECMO is, but that stands for extracorporeal membrane oxygenation. It's basically putting them on a machine to breathe and pump blood for them. Got them on board because we don't know when this patient is going to go down south. And so we then bust out amiodarone. We'll try amiodarone and see if that can then fix that arrhythmia. Try amiodarone, get the drip going there. Again, seems like it's working for a while, but then ultimately does not. Patient gets towards crashing meaning going to cardiac arrest. And so we go ahead and just pull the trigger and put the patient on ECMO. At that point there, you have a machine kind of providing the cardiopulmonary support for that patient and allow for the heart to kind of rest a little bit, allow it to sort of fix whatever its issue is, and then ultimately restore the patient. So that patient ended up going on ECMO, got transferred up, and I think ended up doing well a couple days or weeks later. So again, it'd be nice if all of our drugs are super effective, but sometimes they're not, depending on the situation. But again, kind of think about the different ways those drugs are being used. Are they trying to fix the arrhythmia? Are they just trying to treat the symptoms of the arrhythmia to try to make sure the ventricles are still working functionally? All those type of things. So hopefully that'll help kind of guide you a little bit in thinking about how these drugs are working. Is it rate control? Is it a rhythm control? Do they work for supraventricular arrhythmias only? Do they work for both? Right? So that can be clear when you look at the mechanisms of the drug, and that hopefully will make a sense. Okay. So that's it for me today. Do you guys have any questions? Otherwise, you're free to go. You'll have the quiz you can do this week, and then hopefully that'll give you some ideas about how to sort of collate all this information we've been learning about the past couple weeks in your mind, and then we will meet next week for sort of a wrap up and then a case review sort of thing. Jillian's asking, can you briefly re-explain the difference between relative refractory period and a normal refractory period? So don't think about normal refractory period. Think about absolute and relative. Absolute refractory period means that nothing can come along and trigger off another signal. So let's imagine going back to our drawing here. Excuse me. And so let's imagine we have, our normal cell here. So say it gets triggered, has an action potential, dips down, repolarizes, and goes along, right? During this phase here, typically, this is going to be the absolute refractory period, right? So nothing can come along and cause another signal to happen because those sodium channels are still in a refractory state, right? They're still in the inactivated state. So nothing can happen here that would cause another action potential to occur, okay? But what would happen once we get into the relative refractory period? So let's go ahead and do it. The next action potential here is, let's say we have normal depolarization, little dip, have the plateau, and then it starts to repolarize. But what if something happened to where like another really strong signal came in, either due to say some ischemic tissue that's conducting a little differently, due to the atria firing too fast, something like that. During this relative period, you could then have those sodium channels open again and cause another depolarization to occur, right? And you see And then what would happen if that same thing happened again? And then you cause another depolarization to occur, right? And then you can see that continuing to go on there. That's not great if you're having all these premature beats because the ventricle hasn't had time to really reset itself to be able to fill up with blood and then pump normally again. So again, while this looks like gobbledygook here, you can kind of get the idea of what I'm talking about. So by using a drug that can extend the refractory period, that then it prevents this from happening here because that the absolute refractory period is going to be extended as well. Okay. Let's see. Marissa's asking, I just want to confirm that when you say supraventricular arrhythmia, you mean any abnormal atrial arrhythmia. Sorry, probably a dumb question. No, it's not. Anything happening above the ventricles, I'm calling a supraventricular arrhythmia. Does that include a fib and a flutter? Absolutely, right? So anything above the ventricles. Anything below or ventricles and down is a ventricular arrhythmia. Okay, so that's a very broad brush to paint with in terms of classifying them. Obviously, there are a multitude of different ways to classify that from then on, but for our purposes, let's keep it simple, right? Like the KISS, keep it simple, student is what I say. What other questions can I answer for you? If nothing else, you guys are free to go. And I will see you all next week. Let me know if you have any issues with the quiz or problems or anything like that. I'll get that other prescription assignment done this week and reviewed for you guys. That way we'll be ready for the last one. And then we should be good to go. Thank you all for joining me, and I will see you all next time.